Good morning and welcome to HTM Mixer. Glad to see everyone come out. It's been about 5 years since we've been up here, so we're not social distancing or wearing masks, so that's a great big plus compared to the last time. My name's Brian, and so I want to thank MD Publishing for having me, as well as Cabinet putting the mixer on this year. So what I'm basically going to do is cover on this is kind of the basics of a cath lab. Unfortunately, an hour doesn't really do the topic justice like it should, but I don't think a lot of us want to sit around and talk about it that long either. So one of the things I've noticed over the years working with other techs and just, in general, there's a lot of trepidation working around or in the cath lab for people that aren't really familiar with them. And I'll completely agree. It took me a good while when I first started working up in the cath lab as a biomed to gain the trust of the department, and really it's kind of a hostile environment. There's all these machines and stuff going on that I had virtually no clue, and fortunately I had someone to kind of guide me through it. So, yeah, no, it is. It's kind of a, I don't know, well, this is for myself, and I've noticed other techs have struggled working in there. So hopefully I can kind of peel back the curtain and show what goes on and some of the things they do in there. So first thing we're going to cover is cath labs. And I kind of broke this down into 3 sections because you can easily get down all kinds of rabbit holes with all the different variations of labs and techniques and all that. So basically I broke it down into 3 sections. First one being just traditional cath lab. The next one being EP lab or electrophysiology lab. And then the third one being a hybrid OR. So we'll get started here on cath labs. Everyone can hear me okay? I apologize for sitting. I'm a little mobile, how should we say, handicap right now. So standing's not really an option right now, but I will try and address everyone in the room best I can. So basically, cath labs were originally conceived in the 50s as an experimental way to do non-invasive or less invasive procedures than what they could do back then. So say if you had an issue like, I don't know, that needed addressing, really the only way that they could do it back then was to open you up on an OR table and do it really invasively. So with the advent of fluoroscopy, or kind of the advancement of fluoroscopy and some enterprising, I guess you want to call physicians, they were able to come up with this idea of doing this type of procedure. So it's so hard to see with the light. Can you guys see the pictures okay, or is it okay? So we'll do the best to kind of describe what's going on. So here's an early cath lab from about the late 50s. So they were kind of up and running and getting along with the technology even that far back. And some things to note. So right here is the view screen that the physician would have been using to view the images. Could you imagine the cardiologists and radiologists trying to use something that small? They'd be burning down the lab before they put up with that. But with 1950s technology, they didn't have anything any better. Another thing to note here, here's the image intensifier, which we'll be covering later. And up here is the cameras for the system. So one of them is the camera that shows the image up here on the image screen, and then the other camera is your cine camera that they use to actually record the images so that the physician could go back and look at them. So what made this all possible was fluoroscopy. And basically what fluoroscopy is moving X-ray. So you can think of on your phone, you've got on your camera, you got like, you got your photo mode, which takes still pictures, and then you got your video mode that takes like moving pictures. Well, this is what would equal the video mode on your phone. And so they did have fluoroscopy probably even a decade before they started really using it, other than like the shoe stores, those that heard the story about the fluoro scans for your feet so they could fit your shoes properly, that they're radiating all these poor shoe salesmen and they were dying of cancer for no obvious reason. So they got a little better way to do it and a little better shielding than just a wooden case to stand on. So the fluoroscopy allowed them to see moving images inside the body. And some of the pioneering, like radiologists and what later became cardiologists, said, well, hey, maybe we can actually use this to do procedures inside patients without having to open them up in surgery. So here's a more up-to-date cath lab, and like I said, I'm sorry about the lighting. So here's your screen now, and actually they're quite a bit bigger than this. This one's, a few years old, so they've gotten even bigger. But yeah, the cardiologist can really get a view of what's going on. Thank you. So here's my calibrated stapler that I'm using as my Phantom. So you can see that on a couple images there. Here is the image detector, or the flat panel detector. So this is what's actually making the images completely digital. And down here you can see the X-ray tube, and then got the table. Again, hard to see. Got an anesthesia machine. You got some catheters back in here. So a lot of moving parts and pieces that go on inside in the labs. Angioplasty. So what they were looking to do is to come up with ways to get into the body and do things to help patients recover from things. And so basically what they're doing in the cath lab for people that may not have been in the cath lab very often is they're fixing these coronary arteries. And these are on the outside of the heart. So rarely does cath lab ever involve itself getting inside to the actual chambers. Most of the work on the cath lab is on the outside. So the coronary arteries come right off the aorta. So you have the aortic valve right here, and then these arteries then feed the actual heart muscle. And that's what they're trying to do in the cath lab. So that what will happen over time is the coronary arteries will start to narrow and in some cases actually occlude. And then, the heart's not getting the blood that it needs to work. So normally people notice that fairly quickly. Here's an actual X-ray image of the coronary arteries. So here's your left artery, your circumflex. I believe this is your LAD right here. So like I said, this is what the cardiologist would be looking on his screen. And like I said, I can see why they'd be a 12-inch CRT monitor to look at this stuff, because those coronary arteries are really small and some of them are hard to read. So here's an example of a coronary artery that's got an obstruction. So what they will do is they'll go in through the femoral artery, go up through the aorta, and then they'll come up to the end of the aorta, and then they'll drop a catheter down into the arteries and start looking for any blockages and or narrowing, depending on the problem. Again, I'm sorry for the image quality. So this is actual catheters inside the heart, and you can see, it's probably hard to see from where everyone's sitting, but there's little dots that are along the catheter up along the whole distance on it. And those little dots are little markers that allow the cardiologists to be able to measure where they're at, because they have to come back with other catheters. They normally go up with a general catheter, put some contrast up into the heart, and then find out where the obstruction is, and then they have specialized catheters that they come back to fix the problem. So by having those little markers on there, it shows up real easy on the x-ray, gives them an idea how far they are in the artery and then how far they need to go to do their interventional work. So here's kind of standard procedure. So you got blockage, kind of calcium and other buildup junk in the coronary artery. They'll put a catheter up there, and then this is where the measurements come from. So you can see the little dots there, hopefully, on there. That's the balloon catheter. So they'll put the balloon up there, expand the balloon, push the blockage out of the way, and then hopefully, if it's not too bad of a blockage, then that's all they need to do. And here's another catheter. So, funny story about catheters. So, this is going back to the 1950s, so keep that in mind, almost 70 plus years ago. They had the advanced technology for the time with the fluoroscopy, with the x-ray, and you had the intrepid, I guess call them vascular people, wanting to go up into the body and do their procedures and look around. Well, one thing that kind of got left out of the equation is who made the catheters. You know, so there wouldn't have been no one in the business that would have been making catheters for anyone at the time because it was so leading edge. So the docs would get together and kind of like how women had Tupperware parties back in the day, they'd have catheter parties. And they would get in their garage or their basement and they would buy these flexible TV and radio antennas that were hollow, and they'd have catheter parties. And they'd go down and they would sit down there and bend their catheters and, you know, kind of compare and contrast and say, hey, what can we do with this? And so that's where the first catheters came from. So I don't know if that was FDA approved or not, but I guess if it was a means to an end, then by all means. Here's another example of a procedure that they do up in the coronary arteries. So here you have your balloon with a stent covering it. The balloon would go into where the blockage was, and then they would inflate the balloon, deploy the stent, and then the stent would then replace or reinforce the coronary arteries so that they didn't block again or collapse. So that's, I thought most of the time you're probably going to see someone be getting stents. It's not real often that they can just open it up and hope that it works, because chances are you're going to be back in the cath lab again. Early cath lab technology. So like we had talked earlier, they used fluoroscopy. This particular picture is from the late 1960s, early 70s. So this little device here is called the image intensifier, and we'll cover that in a few slides later. Most of the cath labs, even clear back in the day, were basically a C-arm setup. So they had the C-arm concept fairly early in the development of the technology. One thing that's kind of missing from this is the cameras and some of the other peripheral stuff, but it just kind of gives you an idea that the technology has stayed fairly the same. There wasn't any real huge advancements for several years after they kind of started to do them. So here's an image intensifier, and this would have been the pinnacle of image intensifier technology. This machine was from 2005 is when it was installed. As a matter of fact, I took my last image intensifier lab out like 2 years ago, which was kind of sad because I really liked working on those old labs like that. But enough of the nostalgia. So basically what happens is you'll have the patient down below here, and then you'll have the table, of course, and then you'll have the x-ray tube. And what'll happen is x-rays will go through the table, go through the patient, and then hit the entrance of this image intensifier. Now, this is 100% analog, and so this is what they would have been using clear back to the very early days of the development of the technology. Some things did change and improve over time, but this big boxy thing up here is where the camera lives, and we'll cover some of the cameras. So in some of the earlier pictures, they were like shelves holding the big cameras and stuff. And so by the end of the time that they came up with the technology, they were able to house all the cameras and everything independently inside the II itself. And interestingly enough, this room is the same age. This room was installed in 2005. However, it has the flat panel image detector that is 100% digital. So kind of comparison and contrast of the old technology versus the new technology really coexisted for quite a while. One thing about the image intensifier, a lot of the radiologists, cardiologists like the image that the image intensifiers gave, because it gave an analog image versus the digital images. Now everyone's switched over to digital, so you'll almost rarely see.
It depends on the radiologist's age too.
Well, yeah, and I do agree with them. Especially the older systems that had the TV cameras in them, the image quality against the first and second generation digital rooms was superior, far superior. Now it's advanced. You got, it's like your old 3MP camera that you had, 15 years ago versus what's out now. I mean, a film camera did have better resolution in those days than the early digital cameras. It was the same with this. The early technology was nice, but really the image quality was marginal compared to a nice, well set up analog system. So back in the day, the technology wasn't there to be able to permanently record the images. And so basically they started out and all they had was a live image, and that was it. So if they had to go back and predict or kind of lay out their, I guess you want to call it intervention, or they had to go back and do more work inside the heart, they had no record, they had nothing. So they basically had to start all over with each run that they did. So the way to fix that was called the cine film camera. And it was straight from Hollywood. They took cameras that the Hollywood people were using, 35 millimeter movie film, and they adapted it to the technology. And so what this allowed them to do then is to actually record the images as they were doing the procedure. And we'll cover a little more on how that works. So again, apologize for the image. So over here is your TV camera, and this is what they would see up on the little CRT on the screen. And then on this side, you would have the actual cine film camera. This was loaded full of the Hollywood film that I was talking about, and it would film. It had a lens up here, and it would film the output of the image intensifier. And so with this, so it had two mirrors on it. One would go to the video camera, one would go to the movie camera. And so then basically, more or less, they could get about one run worth of film on each one. And then they would have to change the film out, put in a new spool of film, and then process the old film. So, they probably could get, I don't know, 20, 30 images before the film ran out. And then they'd have to stop and reload everything and then keep going. So it was kind of a cumbersome process, but that was really the only way that the cardiologist could be able to look back and see where he was and what he was doing. Now systems have road mapping, and it's all instantaneous digitally available to them, so they could just press a button and see everything that they've done the whole case without having to stop. So this one's Cath Lab from the 1970s, late 70s. And unfortunately for the cardiologists, the monitors hadn't gotten much bigger or any better. So over here, when I was talking about the cine film camera, so you can see the camera right there on the side of the II. And so this guy here would, this is where the cardiologist would sit and read the film. So the patient's up here, they're doing the procedure, and so he has to go, hey, I need to find out where that obstruction was or where that narrowing was. So he would sit down here, the technician would spool the film up on the one side, run it through the reader, and then spool it up on the other side. And then the cardiologist had a set of foot pedals that he would step on and advance it or bring it back depending on what he wanted to look at. Funny enough, when I got into the business working on cath labs, we still had two of these guys sitting around. And I was all too ready to just, send the stuff to the dumpster and call it good. Well, I was told don't, and I was just whatever. Well, we had two older cardiologists that wanted to look at their own old film studies. And they were from like the 1980s. And I made a comment to the lead tech, and I said, those studies are 20 years old. Don't you think that per patient's physiology would change in like 20 years? And he just shut up and go help the doctor, because I became the film guy. And so I would go in and I would spool up the film and get it all ready and set up. And then I'd have to stand there as they went through their film. When they were done with the one spool of film, then I would then take it out, get the next one they wanted to look at, load it up for them, spool it. And so I got to enjoy the battle phase as far as what that looked like at one level. Another thing that's probably hard to see in the picture, unfortunately, is these cardiologists are enjoying some cake. So I'm guessing this was right before the cath lab opened, or kind of a grand opening celebration. But with those little details. As a matter of fact, this picture is from somewhere in Wyoming, so I'm guessing it's either Cheyenne or Casper. So if you want to know what technology looked like in the 70s in Wyoming, there you go. Pickup tube. So the early systems used a video camera, and this is the actual tube, the video tube that makes the images. And so for decades, this was the gold standard of making images for fluoroscopy, at least the live ones. And so I want to say, probably ditched this technology sometime in the late 1990s. So it had quite a run. This would have been just kind of at the advent of digital technology kind of coming into the world. So I like I said, I would it's the early digital versions. This one was far superior. The only bad part about these is they were really bad at consuming power, and you had to let them warm up. And so if you had an emergency, or there was a rush, the image quality was very poor. And so it took about 15 minutes for these guys to actually warm up and get where they needed to go. But by far, once these guys were calibrated and working like they would, really gave a nice image. So the next step in the technology was the charge-coupled device, and it's a solid-state camera. And that big box that was at the end of that first one that I showed you, the II, the big one, the kind of the end of the line one, had CCD camera in it. And so that's what that big boxy thing. So they were fairly sizable. And if you still have any C-arms that aren't digital, that are analog, still kicking around in the OR and stuff, they'll have this CCD camera in them. I can't think of any of them having pickup tubes anymore. So like I said, if you got an old 9800 or 9900 kicking around in the OR, this is the type of camera that it would have. Digital detectors. So basically going forward, I want to say probably from the mid-2000s on, most of the technology was equipped with the digital detectors. And as you can see, hopefully you can see the picture. So this big kind of, we call the pizza box, is your digital detector. And so, like I said, the X-ray tubes down here, the X-rays go through the table, then you have your patient here, goes through the patient, and then hits the digital detector. You want to take it in simplistic terms, think of it as like a giant electronic etch-a-sketch. So each X-ray beam will hit the the grid inside the detector, and then the grid will record those X-ray beams and then turn it into an electronic signal. And then that electronic signal will then go from the C-arm, and then maybe you can see in the back, you can see some cabinets. There'll be an image processor back in one of those cabinets. The image processor will take those images, put them together, and then display them on the big screen, which is, again, hard to see in the back. It does it instantaneously. I mean, there's absolutely no way that you can get any way to see that it's not. Keep in mind, in a cath procedure, you're looking at somewhere from 15 to 30 frames per second. That's a huge amount of images and information that is instantaneously getting transferred from that pizza box back to the image processor. And now they have ones that go up to 60 frames per second. So I mean, it just blows my mind that they're able to do that much imaging so quickly. And here's a not so happy image detector. Basically, this all in here is the image detector itself. This is a little smaller format. This is a 20 centimeter detector, and the other one was a 30. They make them as big as 40 centimeters. And with the 40 centimeter detector, you can actually do a full body scan in one pass. These guys here, these little guys are the 20 centimeter ones, are kind of designed, they're like a sports car version of a cath lab, because the cardiologists like to get into really tight, close angles to the patient. And if you have that big 40-inch detector on the end, you'd be smacking the cardiologist and the patient. So that's why the different sizes. The 30 centimeters, kind of like the minivan of the bunch. It's kind of good at doing this kind of stuff. It's kind of good at doing the vascular, bigger scans. So it's kind of the middle of the road for the companies or hospitals to purchase. Okay, so now we'll cover an X-ray tube. So here's a X-ray tube. This would be your medium size tube that you would use on like a 30 centimeter detector. Here's the actual tube itself. You've got your cooling lines and your oil lines to help keep the tube cool during the exposures. This big clunky box up here is your collimator. And then this guy over here, at least with GE, everyone has their own way of making pulsed fluoro. So what pulsed fluoro does is it synchronizes the X-ray tube with the detector, and then back in the day with cameras. And so what it'll do is it'll only make X-ray when the detector or the camera is ready. So you don't have a bunch of jumbly images, because if the X-ray is just pumping out X-ray, the detector or the camera will never know when it's supposed to turn on. So what this little in-grid does is it synchronizes the X-ray tube with the detector, and then it makes a nice smooth fluid image across the exposure. So kind of a little trick that they were able to add on some of the earlier systems. They didn't have this, and the images were really jittery, like those old, like you see those old films where they're kind of, choppy and bouncing all around. Well, that's how kind of the early cath lab images were, until they figured out how to synchronize the X-ray tube with the camera, or detector in this case. Then here's the tube without anything on it. For those of you that have been in X-ray, here's your cathode, and then your anodes tucked back over here. These guys here weigh about 250 pounds. So not fun to mess with if they don't behave themselves. Broken cath lab. So to show you, this is a bad day in the cath lab. This machine was, well, had lots of issues. And me and my coworker, George, worked on this guy for about 2.5 days before we figured out what was going on. So in this, oops. So what happened is this portion of the C-arm wouldn't work, so the detector couldn't change its source to image distance, which is kind of important. You don't want to write it up, whoops, right up on the patient's chest, and then you don't want it so far away that your images are like this big on the screen. So not having that working was not available. And then also the table decided to quit working as well. Unfortunately, we went down the wrong rabbit hole, and we figured it was something within the system out here. It was actually in the positioner cabinet. Bad power supply took out the table, and then one of the positioner cards took out the image intensifier, the image detector, and the SID function. So it took us a while to figure it out, but once we got those fixed, then the system was working again. But kind of to be able to look at it with the covers off and see all the stuff kind of hiding back behind things. Another kind of related, but not necessarily the same procedure that they use is cardiac computed tomography angiography, which is a big fancy way of saying a CT exam of the heart. And so what they do is they will use a CT scanner. Say if a patient presents at the ER, they may have some of the symptoms of a heart attack, but not all of them, or they're not quite sure if they need to call the cath lab in. They may run them over to CT, and they can do a nice scan of the heart and see if there's any narrowing or constrictions inside the coronary arteries. And then the doc can call up and say, hey, you need to get the on-call cath lab guys in. It's like a weekend or something, or we need to send this guy up to the cath lab. So that's kind of a handy tool because it's non-invasive. They can do a full scan of the heart. They can look for any issues and decide from there if they want to send them to the cath lab or not. Another thing that they do is with the cardiac stress testing that they test a patient for any cardiac issues, or if they need to send them to the cath lab, they use nuclear isotopes in a gamma camera. And then they make them run on a treadmill, and then they re-examine them and see where the isotopes end up and if there's any blockages within the heart. And then they can say, yeah, well, we need to send you to the cath lab. Well, this kind of eliminates that for people that may not be tolerant or can do the stress test. So it's kind of a nice, quick way to help people without making it too excessive. Calcium scoring. This is another procedure that they use a CT scanner for, and this is kind of like a long-term thing. So you might go in for those, like they give those, like discounts where you can get your heart scanned and checked, and make sure everything's good, like checkups. And so the calcium scoring is to help people keep track how much calcium and obstructions are in the heart. And then this gives the cardiologist a baseline to work with. So if they come back in 5 years, they can be like, whoa, wow, this is a lot. Or they can be like, yeah, you're good. Just keep going. And so that's another type of procedure that they will use a CT scanner for. And so here's the inside of a CT scan. This is one of GE's newest ones. Up here is your X-ray tube. And down here is a big bore system. And this is your giant detector. This is probably about twice the size of your conventional CT scanner. So they can do all kinds of really cool scans with this. A lot of people assume that the reason why they have such a big bore on these machines is for patients that are extra size or extra large, and that's actually not the case. They actually have a big bore because gantry on this can tilt forward and backwards. And if you have too small of a bore, you'll be smacking the patient in the head, or you'll be smacking them down on their knees when you tilt to get these angles. So the big bores are actually so they can utilize this big detector, and they can get a bigger slice of the patient, and they can get bigger angles of them. So just a little tidbit: when you hear about big bore, it's not a bariatric issue; it's a procedural technique issue that they have the bigger bores for. Injectors. So early on in the I want to say, the development of cath labs and the techniques, injectors, not necessarily injectors, but using contrast was fairly early on. And the vascular people using it discovered that, hey, this contrast stuff really works well in getting really good images within the patient. However, the conventional wisdom of the time was that you never wanted to use it with the heart. There was concerns that the contrast and then messing with the heart could either cause injury to the patient or even worse. So in one, I guess you want to say, memorable event, they were doing a procedure on a patient, and they were not even working anywhere near the heart. The assistant to the doctor accidentally injected the patient with the full volume, full bolus of contrast. And the physician was mortified. He's like, we just killed our patient. Well, I guess it didn't bother him too bad, because he decided, well, let's watch and see what the heart does, because he pretty much wrote the patient off. And so they decided, well, we're going to see what kind of images we get from the heart with this accidental, overdose of contrast. So they did the images and watched the heart, and they got fantastic images of the heart, really good images. And the patient made it, had no bad issues, nothing bad happened. Patient got through the accident, and they discovered that, yeah, the heart is an area that we can actually work and examine. And so from that little mistake, that's how cath labs were born. Because up until then, they were all peripheral or examining other parts of the body. They never touched the heart, but that opened up the whole cath lab business there. And so here's your Mark VII kind of modern day contrast injector. And these are a little more, how should I say, regulated and controlled than using a bolus from a syringe to inject the patient with. EP lab. EP lab's kind of its own little world within the cath lab. Doesn't really matter with the machine itself, the X-ray machine, because it's basically the same machine they would use in cath lab or interventional radiology or any of those type of areas. What makes the EP lab special is all the other equipment that goes with it. And so we'll cover some of the things they do in the EP lab. So basically, electrophysiology is about the electrical side of the heart. You have two areas of the heart. You have your SA node, your sinoatrial, and then you have your anterior ventricular. So your SA node controls your atria, and then you have your AV node that controls the ventricles. Now think of it this way: if you it receives a signal from the brain. And so if you're chilling on Friday night watching some movie and drinking a beer, your brain's probably chilled out and telling your heart, hey, just take it easy, we're chilling. Well, as opposed to if you're out on a hiking trail and a grizzly bear shows up and starts chasing you, it's going to tell these guys, hey, we need you now, let's go. And so that's their purpose in the world. So you have your SA node, and basically it's on the above the right atrium, and it's the natural heart's pacemaker. It is responsible for your normal cardiac conduction. So it'll send a signal from the SA to the AV, and then down to your bundle of his. It regulates the proper filling and ejection of the blood from the chambers, and it causes the atria to contract and fill the ventricles. The other one is the AV node. It's your interventricular node. It's down below the SA node, and it receives the signal from the SA node and sends out the signal for the ventricles to contract when it's their time. And so, again, sorry about the picture. So you have your AV node, which is up here. You have your bundle of his down that goes through here, and the fibers that go out and around the ventricles are called Purkinje fibers, and helps the ventricles then contract. So some of the things that they'll address in the EP lab, so will happen over time. People's hearts will kind of get sick. Some of them be congenital problems with the heart that had happened over before. I mean, when they were born with problems. Heavy drug usage, alcoholism, smoking, all those bad things will cause arrhythmias as well in the heart. One of the procedures that they do is called an ablation. And what they'll do is they'll use a mapping system in the heart and some EP equipment, and I call it predator vision because it comes up in all these kind of weird predator colors. If anyone that's seen the movie, looking in purple and red, green, and all this stuff, and that's what the image looks like on the screen. And each different color represents a different pathway in the heart. So say if you needed your SA node ablated, then they would look for all the places of the purple. That's the color they're using for your SA node. And then they're able to map that. Well, back when I got into it, they had to use 4 catheters that they floated up inside the patient to map these things. Well, as the end of my time working on EP, the biomed side of the EP equipment, one of the cardiologists was telling me about that they had developed it where they could use a single catheter, drop it into the heart, and map the whole heart with one catheter. I mean, that's just huge advancement technology. So that's how they decide where they need to do the ablation. If they see like weakness in the signal, or if it's crossing over into other places where it shouldn't, then they'll use the ablation. So after they do the ablation, what they'll do is they'll put in a pacemaker and connect it to the heart. Pacemaker then becomes the new SA node, AV node, or maybe both, depending on what type of arrhythmias you're getting in your needs. And then another thing that they'll do in the lab will be ICDs, implantable cardiac defibrillators, and this is for people that have like fatal arrhythmias that they will actually die from, and so they'll put a defibrillator in there. They'll shock them back without having to immediately go to a healthcare facility. Okay, so hybrid OR, and here's one of those terms that's used rather generally. Basically, it's a vascular cath lab type system in the OR, if you want to break it down. There's all different names for it. It's kind of crazy because you go, depending on what, even in the same health system, they call them different names. But basically, it's a cath lab system that's in the OR. The table is different, table sealed, so that if there's any fluids or OR things that happen in there, they won't get down into the electronics of the table, and they will also mimic the OR tables with their positioning, so they can do the different tilts and stuff, as opposed to a regular cath lab stays fairly flat. So again, hard to see this, but this is a robotic cath lab in the OR. So this special table, and you got your C-arm, traditional C-arm. This one will actually spin 360 degrees, so you can do like a one-slice CT scan with this. Takes forever to process the images, but it will do it. And then this right here is your surgical robot. One of the procedures that they'll often do in the hybrid OR is called a TAVR, and that's called a transcatheter aortic valve replacement. And what they do is they go up through the femoral artery, go up into the aorta, and they can then replace the aortic valve without having to cut the patient open. So it's all done intravascularly, change out the valve, and without any serious surgical issues. One thing that makes a hybrid OR nice, and the fact that it is in the OR, is that you can most of the time move the system out of the way. So here you see the robot all on its own. So if you wanted to use the room for conventional surgery, you could, just park this out of the way and do your surgery in there. Or if you needed to do imaging, then your image machine's just right there. You just grab it, get the remote and park it by the patient, and you can do all your imaging stuff. One of the biggest things that I've seen in the hybrid OR, and it's not necessarily related to the cath lab or cardiac, is AAAs, abdominal aortic aneurysm. And for whatever reason, there seems to be a steady supply of AAAs that is done. And so basically what happens is with age, particularly with men after like 50, their aorta starts thinning and getting weak down in their kind of in their belly area, and things kind of start not going well. There's really good screenings that catch this very early, and so not like back in the day where you brought someone in with a AAA, that was pretty much the end of the line. Very rarely would they be able to actually save them. Well, with this procedure, they're able to save a lot more people. And so one of the procedure they do is an endovascular aneurysm repair. And what they do, it's just like the coronary arteries. You got your plaque, you got your obstruction, you got stuff kind of falling apart. They'll send a catheter up again up the femoral artery, and then they'll get up to where that weakening or where that spot is, and then they'll deploy it. Okay, they'll deploy a catheter, and they'll strengthen that area. And then, a catheter, they'll put a stent in here, and then they'll reinforce the walls of that aneurysm, so it shouldn't be a problem. Really interesting about those stents, if anyone that's been in the cath lab, the stents are tiny. They look like little tiny Chinese finger cups, and they're really tiny. These guys, they actually took one out of the package, and they're about yay long, and they're the size of a garden hose. I had no idea that the aorta was that big of a vessel, but those stents are huge. So this is a pretty big deal. If that cuts loose, then yeah, you're not in a good catheter.
Stretch it and close it down or something.
Yeah, so it's all like bundled up on the yeah, and then there's a balloon under it that poops it out, and then they keep expanding the balloon until it like literally drags itself, because the stents actually have little barbs on them, and so the little barbs will actually then go into the walls of the
catheter itself is not very big, right?
Oh no! Oh well, that one is though. It's small for what you're thinking you're going through in the femoral artery, but it's big compared to like the little guys they use in the cath lab and IR. So it's kind of a neat thing to see. I've had some rather tenuous times in the hybrid OR in these procedures. Always happens whenever I'm working on the lab. They tell me the lab's open, it's yours, don't worry about it. And then they'll come rushing in, hey, we need the lab. And then I'll be like, and they go, well, we got AAA on the way. And I'll be like, say no more. And I'll get as much put back together and get it running for them. Sometimes that works well, sometimes it doesn't. But like I said, I've been through some rather harrowing AAA procedures, so I decided to throw that in.
That's what John Ritter died.
Was it? Oh, wow. And then here's another shot of a hybrid OR. Again, the robot can move around the room, so you can get some really cool shots and angles that you wouldn't be able with a conventional, like, fixed lab. And then, just covering radiation safety, keep your, time as minimal as you can around the X-ray, keep your distance from the X-ray, and whenever possible, use shielding, lead aprons, and other protective equipment to reduce your exposure to the X-ray. And thank you very much for coming out and checking out the chair.